Hello, everybody. Welcome to this second session of the Maternal Mortality in Africa conference. My name's Simon Szreter. I'm here at Cambridge. I'm in the history faculty, and we're now going to hear my good friend and colleague Shane Doyle, who is Professor of African History at Leeds University, author of a book, Before HIV, Sexuality, Fertility and Mortality in East Africa, and currently directing a very important MRC multidisciplinary project based in Kisumu in Kenya, and that's what he's going to tell us about, the aspects of that related to our collective interest in maternal mortality. So over to you, Shane.
Hello, my name is Shane Doyle. I'm giving a presentation today on interdisciplinary perspectives on maternal mortality in Kenya. When I first started researching on maternal health in East Africa, I was working in Uganda and came across a proverb, Okuzala Lumbe, which literally means to give birth is death. It's understood as meaning giving birth is deadly or terrible. And for me, the proverb seemed to indicate that high maternal mortality is not a new problem in Africa. It has a history that needs to be reconstructed and a history that has shaped the present. But when I started to interview local people and mentioned the proverb, they emphasized that Okuzala Lumbe shouldn't just be taken literally. The proverb also associates childbirth with social strain. With disruption of established relationships, it can also lead or reflect to a clash between individual and corporate interests. In many East African societies, ideas of socially appropriate reproduction are very strong, and what this means is that often, of course, births can be considered inappropriate, perhaps because of age, perhaps because of marital status or other factors. Again, when I interviewed local people about the proverb and maternal health, they emphasized that it raises this interesting ethical problem that the health interests of the mother and the child might not align, and again, that the reproductive strategies of the matrilineage and the patrilineage might conflict. So what I took from all of this is that maternal health and maternal mortality are cultural and historical phenomena, as well as biological and medical. This project has focused on the discordant relationships between medical staff and patients or between relatives, which heighten risk. The project that I'm talking about today has focused on Kisumu and Siaya counties in Western Kenya. Western Kenya was chosen because it has high maternal mortality ratios, also because of the previous research expertise of two of the investigators. We were particularly interested in referral systems, and so we chose 3 research sites that reflect the 3 levels within the region's referral system. So one site was the big referral hospital in Kisumu City, another was a mid-level county hospital on the road to Nairobi. This received referral patients and also sent them on. And then we also worked in a small village near the Ugandan border, which had a very basic local level sub-county hospital. It's very clear that few African countries are on track to achieve their SDG Sustainable Development Goal target for MMRs. When you interview policymakers in the region, they emphasize that maternal health is a particularly intractable and complex health problem. So it seemed to us that interdisciplinary medical humanities, which focus on the human rather than the biomedical factors, might have something to contribute in trying to understand why maternal death remains so high in this region. We hoped that our multiple disciplinary perspectives would permit a kind of triangulation of causation. So the 5 people put together in this research team, myself, a medical historian, 2 medical anthropologists, Wenzel Geissler and Benson Mulemi, a linguist, Saudah, and Jane Plasto, who works in theatre for development. As we read about interdisciplinarity, we found that most studies were in reality retrospective, coincidental. We wanted our project to be interdisciplinary from conception. The sharing and blending of approaches was cemented during an initial period of joint fieldwork, where we observed our fellow researchers' methods and we joined in as co-participants. Over the last couple of years, co-researching has continued intermittently, but between times, our interdisciplinarity was sustained informally. So even when we were following our separate research trajectories, doing our own thing, learning was still shared each day during fieldwork. We talked on journeys, we talked over breakfast, or over evening drinks. For this informal learning to work well, we thought we had needed that initial period of methodological shadowing that meant that we would definitely understand where our co-researchers were coming from. We had to understand the methodology first. So the rest of the presentation focuses on these 4 disciplinary perspectives on maternal mortality. And what we're hoping is that through the presentation, you'll see how the methodologies link, how they build on each other. So the first method to talk about is Jane's participatory theatre work, which really tried to focus on the emotional and relational aspects of maternal health. And Jane's approach is very different from how I do oral interviews, for example. Jane worked with groups of women over periods of days or weeks, and the intention is to build trust. What I saw through Jane's work is how women, by acting out key experiences, captured the enduring emotional impact of past traumas. Women revealed how subsequent health-related decisions that they made were shaped by previous experience of abuse or neglect. Again, in contrast to the kind of interviews that I do, performance seemed to draw out the relational or interpersonal aspects of maternal health problems. People emphasized how husbands, female relatives, mothers-in-law especially, would shape the decision-making of the patient. So it really took us away from this initial focus on the binary relationship between the patient and the member of clinical staff. The second methodology is the linguistic work done by Saudah. And Saudah had worked closely with Jane initially and then recurringly. Saudah's methodology involved the use of interviews and questionnaires, and what she's seeking to understand were the obstacles that existed in terms of the transmission and the reception of maternal health information. She started by surveying various medical facilities, and what she was struck by was how much of the medical information that was on the walls, that was given out in booklets, was in the English language. She then involved 43 participants in her study who were interviewed, who were given little tests to do, and who were given questionnaires to complete. Most of these women claimed to be trilingual and claimed that one of their languages was English. But when she tested women on posters, on health information booklets in English language, she found that the majority failed, that they did not have the kind of functional, technical English that would enable them to understand this kind of maternal health information that's being disseminated. Again, when she interviewed pregnant women about recent attendance at antenatal lectures, they reported that they couldn't really remember much that they'd been told. They'd often had to walk for maybe 1.5 or 2 hours to get there. They then had to wait in the sun often for an hour. They were hungry, often nauseous and tired. They were not in a good place to receive information. And they also said that they found the way that the nurse midwife gave them information was very difficult to absorb. They'd be speaking in one of the vernacular languages, and then suddenly they would code switch. They would drop out of Doluo or Kiswahili and start speaking English because they'd come to some terminology that was too technical, too medical, and they didn't have the vernacular terms. So the women would be listening and understanding, and then suddenly they would be lost as the clinician shifted into English. When Saudah asked about the one-on-one encounters with nurse midwives, hoping that this would be a more productive encounter, what women reported was that examination. Whenever the nurse midwives spoke to the women, then what they said tended to be didactic or tended to be very rushed. Often the women would be told that, for example, you have malaria, you need to take this medicine, and you need to take, say, 2 tablets 3 times a day. Saudah would interview the clinical staff and say, okay, tell me some of the typical things you tell a patient during an examination. She then noted that down and then went to test the understanding of the 43 women involved in her study, and she found that repeatedly women failed to understand the medical information in the way that it was conveyed. So there's a real problem, she found, in terms of the dissemination of medical knowledge and guidance. Through her interviews, Saudah found that problems of communication caused women to seek maternal health knowledge and care elsewhere. Women knew that this wasn't really working in terms of their encounter with the biomedical system. Most women reported that they sought advice and antenatal care from traditional birth attendants, or TBAs. And women described these TBAs as having more understanding, as communicating more comprehensively. And they just appeared more caring to these women. In a previous study in the same region, Rutenberg and Watkins emphasized that when women sought information about reproductive health, they wanted to get that information from women who seemed to be like them, who seemed to have the same kind of understanding of the world. And this led to about half of Saudah's informants seeking out maternal health guidance from elderly religious leaders. So again, you have this kind of multiplicity of information with pregnant women not prioritizing the information that is being received from biomedical staff. And partly this is because most women felt that biomedical staff were rude, were difficult to deal with. Many women said that they would only encounter the medical system for the very minimum. They would go for the antenatal clinic at the start to get registered, and then they'd go for delivery, but they'd go as late as possible because they wanted to minimize the risk of being criticized or publicly humiliated. The third methodology is historical. What my own research in archives and hospital records and through interviews with elderly women and retired staff revealed was that there's a kind of overlying agenda with maternity care. And the secondary scholarship emphasizes that this is not new. This has always been there in the provision of maternity care in Africa. Today, maternity care is driven by a desire to achieve key international targets relating, say, to SDGs, but also by a desire to use maternity services as a means of evaluating HIV prevalence in the community, or promoting family planning, or ensuring mass childhood immunization. So maternity care comes across in speeches and so on as a priority. It often feels on the ground as a kind of conduit to the achievement of other priorities. So in this medical unit here, this poster, there's much more emphasis on HIV than there is on antenatal care and maternity care per se. And you would also notice that there's much greater success at achieving the HIV goals than at achieving the antenatal goals. In the past, maternity services were surely less target-driven, but they're also much more ambitious in terms of the larger goals. So in these slides from Nancy Rose Hunt's Colonial Lexicon, you get a sense of a sustained effort to transform knowledge and to transform behaviors. In the Belgian Congo, the colonial government sought to use maternity services as a means of ensuring a larger, more productive, more disciplined workforce. After decolonization across Africa, maternal health workers were tasked with constructing a new kind of national citizen, capable of delivering a distinctly African modernity. Right across the continent, maternity services had been pioneered in the early 20th century by missionaries, who regarded pregnancy and childbirth as periods of transition and vulnerability, gateways not only to personal conversion, but also to societal transformation. For the missionary doctor Albert Cook, working in East Africa in the 1910s, 1920s, indigenous midwives who worked in the rural maternity centers set up by the Anglican Church were beacons of light, who would convert local women from what he termed the sewage of superstition and turn this into godly fertilizer, sowing the seeds of hygiene and Christian familyhood in African villages. In these varied constructions of maternal healthcare in the African past, the theme of respectability was a constant. So maternity centers sought to inculcate a kind of model of progressive rectitude. Nurse midwives claimed, and it seems received, high status within their communities. Whenever I went to try and interview retired nurse midwives in their home villages, these were women who were universally known, who were always given the honorific sister. These were women who said, yeah, we're still consulted, usually outside of local clinics' opening hours. These women would be woken up in the middle of the night, and they took it as a matter of professional pride, never to complain. In this extract from an interview, this elderly former nurse midwife explained that she wanted to become a nurse midwife. Whenever she was a child, she had this experience in a hospital. She fell sick. She saw the trainee nurses. She said, they looked so smart in the uniforms. I wanted to be like them when I grew up. So nurse midwives back then had this kind of aura of prestige, of glamour, of professional progressivism. Today, by contrast, both informants and the Kenyan media depict nurse midwives as being motivated above all by financial gain rather than by vocation. Newspapers and oral testimonies portray staff as neglecting patients during strikes, in the quest for higher pay, allowing patients to deliver their babies without supervision, being recurrently violent and rude. So in my research with elderly people, and also in my and colleagues' research with current staff, I tried to understand what is it that is making the medical staff have a kind of idea of an ideal of respectability which conflicts with local communities, which doesn't seem to resonate with how the staff are depicted in the present. So one of the things that became very clear is that medical staff think of themselves as being fundamentally different from the laity, from ordinary people. And their difference is not so much something that they expect women to emulate, it's something which they kind of hold as a form of distinction. Most nurse midwives have been trained in church-run institutions. It's very common to get a sense of them having a continued strong sense of moral superiority. What's even more powerful and more pervasive is a sense of self-sacrifice. These were women who had delayed marriage until they'd completed their tertiary education, their full training. They had endured multiple transfers for work. These were women of immense self-discipline who had endured familial separation again and again. These were also medical staff who had spent their careers disseminating the ideals of family planning. They had told women again and again to delay the inception of childbearing, to have long birth intervals. They had categorized geriatric and high-parity mothers as high risk. And beyond all of this extra new cultural material that they had absorbed, women had retained indigenous Luo ideals of endurance of pain during childbirth. Women were not supposed to express pain. They were supposed to be able to suffer in silence. So this is how nurse midwives are thinking about themselves and about others. And what I found was that when I then went to the villages and interviewed women who I thought were eminently respectable. So for example, one woman who was parity 5, she's in her mid-30s, she was married. She reported that the previous year, when she'd gone to antenatal clinic, she'd been mocked by the nurse midwives for her lack of sexual control. Why is an old woman like you coming here again to have another baby? Adolescent mothers receive particular condemnation, even if they're married. Yet when I interviewed grandmothers about their own age of first birth and what was common at the time, it seemed clear that traditional age at first birth was substantially lower in the past than it is today. So there's this strange disjuncture that's going on between the village and the clinic. And again, many informants reported being slapped or abused if they expressed pain, often in very humiliating ways. A common phrase that is repeated is, nurse midwives would ask, "Did you scream like that on the night you conceived this baby?" The fourth methodology was that of anthropology, techniques of observation and interviewing. And what the anthropologists were trying to do was to think about the context within which clinics operate. You know, clinics are part of a continuum of health-seeking behaviors, and they're also part of a competitive marketplace. So this began with Mulemi sitting quietly in antenatal and delivery suite triage rooms or outside waiting areas, and just observing, becoming part of the background. And what he would do was listen in to pregnant women talking to their neighbors in the queue, and then wander over and listen to the clinical encounter and contrast the two. And what he found repeatedly was that patients' fears were not expressed to staff, that patients' background stories were not sought out, the patients returned home with questions that were unanswered. From what he observed, it seemed as though the staff primary focus was on achieving targets and recording metrics. When he took patients' details and asked if he could come along a few weeks later and do a follow-up interview, what he found was that often these patients would reveal undisclosed medical context that they hadn't felt able to talk about in the clinic. He also saw that these women received much greater respect in their home contexts than in the clinic. And the last thing that was very clear from the observation process was the universal lack of resources and understaffing at all levels in the referral system. And this contributed, he thought, to nurse midwives' low morale. He repeatedly heard the staff saying, "We can't do our job properly. We can't live up to our professional ideals." Interviews with maternity staff highlighted a generational shift in self-regard. Women who are working as nurse midwives today emphasize how much public criticism they receive and how hurtful it is. They get it from the media, when they're walking down the street, they get it from their neighbors back home. One head of a maternity unit told us that she was so fed up that she decided to move house much further away from her clinic and commuted by car. And when she moved there, she told her kids, "Don't tell anybody what my job is." And she'd only ever wash and dry her laundry, her uniforms, indoors. So there's this really sharp contrast in how even the uniform is regarded today. Then so Geissler's work sought to understand why TBAs were so popular compared to biomedical midwives. And what he found when he was interviewing with me in terms of our continued joint work was that TBAs in this region are actually not very traditional. These are not very traditional birth attendants. Most TBAs in this region are products of post-Alma Ata primary healthcare. TBAs did exist in the region historically, but they were not very common. Mostly women preferred to deliver themselves. When TBAs were involved, grandmothers told me that those women were really harsh. They would slap, they would abuse the mothers, they would query their morality. Over the last decade or so, the biomedical system has claimed a monopoly on the provision of delivery services, and this has been backed up by legal penalties. This has caused TBAs to reposition themselves as doulas, as supportive counselors, birth companions, masseurs. TBAs today have a place in the maternity marketplace that is produced by popular experiences and depictions of biomedical care as aseptic, as target-driven, as unsympathetic. In other words, TBAs have reinvented themselves in contrast to the way that nurse midwives are understood today. So let me finish with 3 sets of conclusions. The first is that there's a striking disjuncture between the ways in which maternity staff are criticized in many venues, and then the way that they come across in interviews. They seem humane, thoughtful, but above all frustrated. Staff repeatedly refer to burnout, to severe understaffing, to stockouts, to overcrowding. It seems to us that the crisis is in terms of policy. Policy shifts have increased pressure on the system, but not enough resources. Maternity care seems particularly vulnerable to tokenism and to targets. There have been improvements in maternal health management within and between medical facilities. Referral systems are definitely better managed in recent years. There have been some technical enhancements recently that have reduced death from postpartum hemorrhage, it seems. Maternal death audits have definitely become more professional over the last decade. From my review of the records that have been kept, there is still no aggregated review. There's no kind of systematic learning from these audits as they accumulate. Above all, what's clear is that maternal mortality ratios in Western Kenya have remained stubbornly high. So despite all initiatives over the past decade in the regional referral hospital, MMRs are more or less the same as they were back in 2011, and more or less the same as they were in regional referral hospitals in East Africa in the 1960s. I can't think of any other medical metric where you could say that in the region. Finally, of course, we have to think that MMRs are a symptom of a wider pattern of poor maternal health. There are strikingly high levels of stillbirth, neonatal death, fistula, and all of these problems have multiple causes. But a common underlying problem is the limited engagement with biomedical services that is reported by pregnant women and maternity staff. This project has highlighted that, of course, understaffing and under-resourcing contribute to this. But in the 1950s and 1960s, MMRs fell from an average of 4,500 to 500 within Ugandan referral hospitals, despite a trebling in the number of attendances. In part, this historic success reflected a new commitment in the mid-20th century by clinical leaders to cultural engagement, to trying to understand where patients were coming from. Our research indicates that renewed efforts to provide respectful, culturally sensitive maternity care would be likely to improve clinical outcomes as well as staff morale. Thank you very much.
Well, I'm sure everybody will have very much enjoyed, as much as I did, Shane's account of his multidisciplinary project and the many issues and some of the findings that are coming out from it. So please don't be shy and put your questions in. We've got, in fact, already a couple from Yulia Hailovich. First one for you, Shane, is how have the responsibilities of midwives changed over time in both in your location of Kisumu and perhaps more widely in Kenya, if you can say something about Kenya as well, but and also what was the impact of colonial and post-colonial factors on these changes in midwife responsibilities?
Okay, thank you. So it's a very big set of questions. I'll try and answer these aspects of the questions and see how that goes. So I guess the first thing to say is that the question in my mind relates to two different kinds of midwives. So I think it's necessary to think about the biomedically trained nurse midwives, and then also what are usually referred to as TBAs, traditional birth attendants. And I think it's important to see that these two groups of mostly women have worked in a kind of often conflictual relationship over the past century. I guess starting from the beginning of the recorded story, then the focus is on mission-trained medical midwives, and as I was saying in the presentation, their goal was very much to use childbirth and pregnancy as a transformative and evangelical kind of project. You get a secularization through the post-war period, and the colonial state feels an obligation to kind of level out the provision of medical services, including maternity services. So in the, if you like, the gaps between missions, the geographical gaps, then you tend to get state services springing up. Once you get to independence, then there is a desire to try to replicate a Western or Northern, if you like, model of healthcare with large referral hospitals and then feeder local units that are located in the more rural areas and that help women to be moved in times of crisis. And that is something which is a heavily politicized project and is something which leads to tensions often between local politicians and national politicians. And the region that we've chosen to work on around Kisumu, we chose partly because of its particularly fractious relationships with the national government. So the Luo people have more or less fallen out or been fallen out with by central government from word go, and that's, they have this kind of sense of neglect and of the centre not caring about the region's interests, including the medical interests, and that is part of the context, I think, which helps to shape the story of maternity care here. One of the things that is particularly interesting in recent decades is that the TBA story is one of flux. So what you get in the late 70s, 80s is a desire to train up local women to give them the skills and equipment to do basic biomedical midwifery. What is felt after some time is that there are too many deaths that result from this. It is not possible to train local women adequately to cope with the multiple things that could go wrong. And obviously part of the problem is that there isn't an effective ambulance system to take women in crisis. There aren't, before the late 90s, there aren't phones for people to call for help and so on in most rural areas. So what you get in the last 20 years is an increasing desire to achieve a monopoly of maternal care by medical institutions. So there's a push to bring women into medical institutions to give birth and to exclude TBAs from any part of the process beyond acting as kind of helpers or support people. And I suppose that is one of the big questions for African maternity care. How do you achieve a kind of universality of coverage if you are insisting on institutionalizing maternity care? Because every village cannot have a clinic that can provide maternity services. So I guess that's one way to address that question.
Okay, thanks, Shane. Well, we've got actually there's two or three, in a sense, they're really like follow-up questions focusing on the issue of TBAs, which people seem to be very interested in. So if you want to make a note, I'll give you, I think they're all kind of pretty much related to each other. First of all, Yulia asked a follow-up. Can you please clarify how TBAs are employed? Are they just individuals or are they part of some kind of community care? And then Tolupe Fadei asked, to what extent would you agree that the acceptability of TBAs owes much to the fact that they culturally understand the people, and in particular they understand motherhood? And then thirdly, Margaret and Jenga asked, how would you characterize the relationship between members of the formal health system, the midwives and the doctors on the one hand, and then TBAs on the other hand? Is it antagonistic?
Okay, thank you. Okay, so I was saying in the talk that there are two different kinds of TBAs. So there are what you might think of as truly traditional TBAs, and these are women who maybe learned how to assist during childbirth by watching their mum or their auntie or grandmother. Sometimes these are women who are kind of healers who say that they had a dream or a vision which in which they were told, you know, you should help women to give birth safely. And then there are women who were trained to be community health workers, and they're often called TBAs, but their true title would be CHV or CHW, so community health volunteer or community health worker. And these are women who are providing a kind of barefoot doctor provision, and that's including basic midwifery. So what we have seen is that the most traditional kind of TBA, they have been particularly targeted by the state, which has sought to punish them where they have continued to help women to give birth. The kind of community health worker has been much more concerned to comply with the state, to not help women in emergencies because of the risk of losing their status. So those community health workers, they sometimes are employed on a low basic salary, and sometimes they just get a little bit of expenses money. And what they seem to value is the access that they gain to training, to different kinds of roles, which do bring in money. So the kind of monetization of rural healthcare is a complex story, and it is tied up with respectability and status, but it's something which fluctuates. It's not steady, if that makes sense. The second question was about the acceptability of TBAs, and whether they derive that acceptability because of their cultural knowledge of the communities, and I suppose they're being part of the communities. I think that is absolutely so, according to the oral testimonies that we've received. And many women who've talked about their experiences of encountering TBAs, you know, they emphasize this phrase, you know, these are women like us, or these are women who understand us. And there is this feeling that medically trained people don't understand us. You know, even if they're from the region, there is a sense that they've become distant through their training. You know, they've been kind of professionalized out of cultural proximity, if that makes sense. I think the value on motherhood, you know, that's something that people haven't talked about much, but I think it's kind of taken for granted almost. This is an area with historically quite high fertility, quite low infertility. So, you know, not being a mother was pretty unusual, I think. So it's kind of talked about much less in Western Kenya than it had been in Uganda, where I researched previously, if that makes sense. But there is a sense that, you know, if you encounter a newly qualified biomedically trained midwife, then, you know, what does this woman really know about the stresses and pressures of being pregnant in a rural community, and so on and so on. On the third question, how to characterize the relationship between medics and TBAs? Is it antagonistic? You know, the basic answer is generally yes, it is antagonistic, or at least it always has the potential to be antagonistic. And one of the things I was trying to emphasize in the talk was that there is a very strong sense of market competition around maternal health care in Kenya. And, you know, on the face of it, the competition is between the state providers and the private practitioners, many of which are church-run, but often they're secular private. But there is this third branch, if you like, of the market, which consists of the TBAs. And the TBAs are very much aware of the flaws of the biomedical system, and they seek to present themselves as being not like the flawed biomedically trained staff. You know, so they provide a kind of foil to the biomedical system, and the biomedically trained nurse midwives, you know, they create this kind of sense of resentment that the TBAs, you know, kind of come across as being nice, you know, because they don't have to deal with the kinds of pressures that you encounter in a hospital, in terms of the numbers of women coming in terms of the professional standards that are demanded but not supported in terms of materials and staffing and so on and so on. So there are many reasons for this antagonism. Some of it is legal. You know, there's a sense that the biomedical staff are supposed to be policing the TBAs, you know, reporting if they are, you know, helping women to give birth, and then it's not working, and then the women turn up in the hospital, and, you know, the medics can tell somebody's tried to, you know, deliver this baby already. What do I do? You know, do I call the police? Do I let the local administration know? So there are multiple reasons for antagonism. You know, obviously it's not always antagonistic, and some TBAs emphasize, you know, I know what I'm supposed to do, and I don't do anything beyond that, and I try and bring women to the clinic when they need it, and so on. But the overall atmosphere is one of kind of structural antagonism, and often a kind of a personal antagonism.
Right, thanks, Shane. Now we've got a couple, quite well organised these questions. We've got a couple on midwives now. One from Rachel Taylor saying that in her own research, midwives were seen as possibly sexually suspect because they worked overnight. They worked with men. She says she found they were often divorced. Did you find stereotypes like this in Kisumu? And then a second question about midwives is from someone anonymously, just wondering how midwives are allocated to specific areas. Is there any attempt to ensure cultural or linguistic understanding? And considering, of course, what the linguist Saudah found in your team, that's a pretty relevant issue, I guess. And then actually I've just noticed the third one we may as well have a look at as well. Did nurse midwives working in publicly funded institutions have different reputations or levels of regard than those working in private or missionary institutions? So you've got a clutch of 3 questions there about midwives. I suspect we won't have time for an awful lot many more questions, but there is going to be, there's another interesting one after that, after you've finished talking about those, about midwives.
Okay, I'll try and be a bit more brief. So
I'm sure people want to hear what you have to say.
Okay, thank you. Thanks everybody for these questions. Great. So the first question about nurse midwives as being sexually suspect, that isn't something that I have heard, and you know, I guess I'll try and see if I can find out information on that. You know, I never asked the question, and yeah, it's always frustrating when you get near the end of a project and you think I should have asked that question. What was coming across much more was that the nurse midwives were trying to assert a respectability which they felt was difficult to achieve in the face of media kind of monitoring and criticism, and in the face of a lack of institutional support, so that they find it difficult to do their job well. You know, they often weren't paid, so it's difficult to maintain the kind of professional, you know, visual status of being a medic. You know, if you couldn't keep your car on the road, you know, is kind of a bit demoralizing and so on. But the sexual suspect issue, I hadn't heard so much. So I will follow that up. Thank you. How were midwives allocated to specific areas? So generally, that's something which seems to evolve over a person's career. So early on, you tend to be allocated almost at you know, not quite random, but you don't have much control over where you're appointed. Once you marry, you tend to have more leverage to say, you know, my husband needs to work here in this area, and I'd like to be employed nearby so we can live together. And then when you have kids, again and again, and especially towards the end of your career, you're much more likely to be able to say, you know, I need to kind of set myself up for post-retirement. And then, you know, people often get kind of appointed home, if you like. The area that we're working on, the Luo-speaking area of Western Kenya, you know, it's very large. So there's a lot of potential to be notionally working in your homeland, but you could be, you know, 60, 70, 80 miles away from your true home. And, you know, so there's a question then about how local you really are. Quite a number of the senior nurse midwives that we interviewed were not of the Luo ethnic group. They had married in often. So they said, you know, we do understand the vernacular, but we don't speak it necessarily perfectly. So there may be questions there in terms of you know, the kind of the cultural proximity between the patients and the staff. Did midwives working in publicly funded institutions have a different reputation or approach to private or missionary institutions? And absolutely, yes, they did. So one of the things that was really clear when I interviewed staff in the church-run institutions was how financially precarious these institutions were, how deeply affected they were by shifts in policy which made public health free for maternity care. So publicly funded institutions sometimes in the past have been free for women, and private institutions weren't. And that has changed over time. But in the moments when the private clinics were competing against a free service, then they felt they really had to up their game. And you get this real intense pressure from the hierarchy of these private institutions to be really nice to the patients, you know, to be extremely polite. And again, the kind of logic is that you're showing up the public health service for being rushed and uncaring and impersonal. And they're able to achieve this partly because the numbers go down. You know, they're relatively more expensive, so they're less busy. So what you have then is a sense that if you can afford it, then you would prefer to go to a church-run clinic. The secular private clinics are seen as a bit iffy because they are so obviously money-minded, and they don't have this kind of Christian ethos of care, which is something that the public, you know, believe does exist. The nurse midwives who work in the private sector are quite keen to get into the public sector because even though the wages might be a bit lower, the potential for highly paid work on projects is much greater, and also the potential to get publicly funded higher level training in Kenya or abroad is much greater. So, you know, I was always surprised that early on in the project, whenever I was interviewing women in church-run institutions, which seem really clean and well organized and not hectic, and very, you know, clearly, you know, well staffed. And the staff would say, "Yeah, I really want to get into the public service." And I'm saying, "You know, really? You know, why do you want to do that? It's so much harder, you know, so much more stressful." And then they list the reasons, you know, what the practical advantages are. So there are these tensions across the different elements of the maternal healthcare system, which I think are very interesting, and, you know, on some level feed into the broader problem of maternal mortality.
That's fascinating, Shane. So we've got one more question, but I'd like to allow myself one as well, which follows up on what you were saying there. So the one more question, so we don't miss it, is interesting question about from Florence Nabwire, did self-deliveries come up? She says these are common in rural Nyanza and Western Kenya, a sign of strength and endurance. So that's probably a fairly simple question for you to answer. And the question I wanted to ask was about, if you like, the politics of striking and protest. You mentioned how in some of the newspapers that was being portrayed as selfish medics trying to raise their pay and so on. But on the other hand, you also said that this was also about trying to defend the resources they had available in difficult times because they were frustrated that they couldn't do the job in the way they wanted to, which would kind of feed more into that set of motives you were just talking about for joining the public sector, even though it was under pressure. And I was wondering whether you felt these were just two, you know, rather politically opposed opinions of the same action, or whether, you know, in fact, the nurses and their motives were being rather misportrayed by some of the media. And I suppose the way one could diagnose that is by looking at the editorial stand of different newspapers and saying, yes, we can predict what that newspaper will say, and we can predict what this newspaper. I mean, so what's the politics going on there? But I think you'd probably better first of all answer the easy, perhaps the straightforward question about self-deliveries.
Yeah, thank you. Yeah, so again, one of the things that did strike me when I started research here was that self-delivery was something that older women emphasized as being a kind of ideal. And my colleague Wenzel Geissler, one of the other researchers who'd worked in this area since the 90s, said that, you know, it was really common back in the 90s for women to talk about, you know, here's my baby, and nobody knew I was delivering it. You know, I got the pains during the night, and I just quietly went outside and delivered the baby myself, and in the morning said to my husband, look, here's your new son, you know, and nobody knew because I was totally silent. And this kind of model of heroic motherhood, which is quite problematic for younger women who, you know, feel that they you know, aren't able to live up to that because they are not allowed to deliver at home effectively. You know, it's something that is really problematic to do in the current health system, and could lead to various penalties. And also, you know, there's just a sense that, you know, really you don't make any noise at all when you're giving birth. You know, how can a young woman really achieve that? What's interesting is that many of the biomedically trained nurse midwives seem to have accepted this kind of ideal of not complaining, not making noise, so that when women do, you know, make noise during childbirth in the hospital, they're criticized, and that's something that is very striking. You know, so many women have complained about being told off, you know, for you know, whimpering. Even. So the politics of striking and protest I mean, the Kenyan media, you know, does have a kind of a range of political views within it. It's not so obvious that the criticism is from one political side or the other. It seems pretty common. I mean, what's again strikes me is how frequent coverage of maternal health is in the Kenyan media. You know, on the TV and the radio, but especially in the newspapers. You know, my research assistant who sends me photos of newspaper coverage, and it's just, you know, it's almost every week there's a major coverage of some aspect. It's hard to keep up with it, and that is striking. So this is a theme. Maternal mortality is a theme that is not neglected in public discourse. It's not neglected in public policy, but there is this disconnect between quite activist policy and quite engaged public opinion, and really quite radically underfunded public health institutions. And I think the frequency of strikes is, you know, obviously primarily about pay being too low, but also being infrequently paid, irregularly paid. But it is also about a sense of there being a need to maintain a kind of professional standard, or potentially even being held to account to professional standard, which is impossible to affect, if that makes sense. And one of the audits, which have become so common and so much more professionalized over the last decade, is that they you know, implicitly at least emphasize that you're being held to account against these standards. And, you know, staff are never really penalized through these, but there is this sense of being evaluated and monitored, and the staff really feel the stress and pressure because they think, well, it's impossible to avoid making mistakes or bad things happening because we don't have enough staff, or because, you know, the referral system doesn't work adequately, and so on. So there is this sense of the strike being about a larger discontent, not just about, you know, the immediate issue.
Okay, well, thanks very much, Shane. We unfortunately have to bring this Q&A to an end now. And I know that one or two questions were, I think we covered most of the issues that were raised in the questions. So I think we now take a short break, and then we come back all together, and then there's some breakout possibilities, which any other questions can be answered. But for now, thanks very much to Shane for this very interesting account of a project, very important project, which we hope will be in due course influencing ministers in Kenya and doctors and midwives and nurses, indeed. Okay, thank you very much.